All right, so we've started the webinar, but we're going to wait a few more minutes. We have a few attendees here, but we'll wait till we have a few more here, and we'll get started.
All right, I'm back.
Great. Okay, I think we'll go ahead and get started. I'm sure people will continue to trickle in as time goes on, but in the interest of time, we'll go ahead and start things up here. Good evening, everyone, and thank you for joining us for this webinar, part of the RFS webinar series for Stroke Awareness Month. My name is Jacob Fleming, and I'm a member of the SIR RFS Neurointerventional Service Line, and it's my pleasure to introduce you to tonight's presentation on stroke intervention and modern IR training. Before we begin, I would like to make several announcements. First, we have another stroke webinar coming up this week. The next one will take place on Sunday, June 3rd at 8 p.m. Eastern, same time as this webinar. And the topic will be an IR perspective of stroke care and intervention presented by Dr. Sabine Dond. Second, we encourage you to participate in this webinar by typing your questions into the text box on the right side of your screen. At the end of the presentation, we will read from these questions and do our best to answer as many as possible. With that being said, it's my pleasure to introduce tonight's presenter, Dr. Martin Radvany. Dr. Radvany received his medical degree from Northwestern University and completed a residency in diagnostic radiology at Tripler Army Medical Center in Hawaii and a fellowship in interventional radiology at the Johns Hopkins Hospital. He practiced for 9 years at Brooke Army Medical Center in San Antonio, where he served as chief of the IR service before he returned to Johns Hopkins in 2007 for a fellowship in interventional neuroradiology. He joined the faculty at Johns Hopkins, serving as program director for the Interventional Neuroradiology Fellowship at the Johns Hopkins University School of Medicine, as well as the chief of Interventional Neuroradiology at Johns Hopkins Bayview Medical Center. He was subsequently recruited to establish the Interventional Neuroradiology program at WellSpan Hospital in York, Pennsylvania, and led the program to attain Comprehensive Stroke Center certification in his 3 years there. Recently, he has returned to academics as professor and chief of interventional neuroradiology at University of Arkansas for Medical Science in Little Rock, Arkansas. Dr. Radvany is also an extremely valued and productive member of the Society of Interventional Radiology and has been named Fellow of SIR for his efforts, including teaching the annual stroke course at SIR. We're pleased to hear Dr. Radvany's perspective today, and I hope you'll join me in welcoming him this evening. And with that, I'll turn it over to you.
Can you hear me?
Yes.
Okay. Thank you for that very kind introduction. So I was recently also appointed to the JACO Stroke Technical Advisory Panel, so I have some insight from the hospital side as well as what's going on there. So let's kind of move on. These are my disclosures. So we'll talk about training pathways and what are the current pathways for radiologists to get to INR. We'll delve into what the current training guidelines are, because I think it's very important to understand what they are and understand kind of where the society's coming from and what kind of the requirements are. Then we'll talk a little bit about the barriers to IRs performing stroke, and then we'll talk finally about what is SIR doing and why. So you all are probably fairly familiar with this slide. I got this at the SIR website, and it talks about the IR training pathways. I did the traditional pathway, where I did the full fellowship, internship, residency, and then when I went through fellowship, it was actually a 2-year fellowship. So my PGY 6 and 7 years. Now with the changes, there's going to be kind of the traditional pathway and the independent residency going through 2020. Actually, the traditional pathway is offered until 2020, and then the other two choices will be the independent residency and the independent residency with the early interest or early beginning in IR. You can see that these programs are fairly lengthy. I mean, it's 7 years, 6 years, so not that much different. If you want to add INR onto this, or endovascular neurosurgery, that definitely extends things. So what is the current pathway for radiologists to become an INR? Well, internship, residency, and then diagnostic neuroradiology fellowship. Most of these are a year long, some are 2 years. The challenge is getting and when I say ACGME, this is the important part to remember, ACGME pathway. But it's the 100 neuroangiograms and then 6 months of training. And this is a combination of neurosurgery, vascular neurology, and neurointensive care, and that can be performed during residency. Then there's the Interventional Neuroradiology Fellowship, which is 1 to 2 years, depending on the program. And really what determines a lot of these things is what's your case volume? If you go to a busy program, you can potentially get these cases you get enough cases in 1 year's time. 100 diagnostic neuroradiology or neuro studies, that could include interventions. You have to be pretty aggressive and be involved in that, and at the same time, you're doing diagnostic neuroradiology. So it's quite a bit to put in a very short period of time. So looking at the pathways and adding the training, so if you were to do the comparing the proposed pathways and you look at what the proposed INR pathway is, if you went through that whole pathway, it would be 8 to 9 years. That's a lot of training. And especially if you look at the independent IR residency, that's already 7. So having said that, we'll look at what the training components are. So I mentioned previously that the formal training, neurosciences, to understand the pathophysiology of vascular disease. This is something that you're going to gain by doing rotations in neurology, vascular neurology, spending time in the neurocritical care unit, and time on neurosurgery. The procedural skills, those really you're going to pick up, again, during your residency and fellowship. And obviously, you're going to start off doing less advanced cases, and as your wire and catheter techniques improve, you're going to move on to the brain. The one thing to really remember is the brain is probably the least forgiving part of the body in which to do procedures. Even very minor things can be catastrophic working the cerebrovascular circulation. So it's really, the technical skill level at that level, the room for error is very small. And then finally, the clinical training, which is also very important because you really have to understand how to manage these patients. I think that's one of the critical things about the difference between being a technician and a physician in interventional radiology is gaining the clinical skills to manage your patients. as opposed to doing a case, doing this great case and then turfing it off to somebody else to take care of the patient. That is not going to suit you well in the long term. It's really important to, if you're going to try and develop a good clinical practice, you have to provide longitudinal care to these patients. You need to see them in clinic, so you have to take consults. You then talk to them, you have to do the procedures, and after you've done the procedures, you got to round on these patients. You got to see them afterwards and follow them up. And some of these disease processes, we follow patients for lifelong, follow-up imaging in some cases. So these are all really the different components that go into these training requirements or training suggestions. And this is actually taken directly from the training guidelines published by Dr. Connors back in 2009. So these guidelines, we touched on this earlier, but 100 cerebral, neurovascular angiograms prior to even beginning endovascular training. As a comparison, cardiologists have to have in their diagnostic training before they become interventional cardiologists, they, I believe, have to have 300 coronary angiograms before they're even allowed to start thinking about intervention. So it gives you some idea of what the expectations are. The clinical neurointensive skills, it's something that you can gain through your internship, residency, even fellowship, depending on the organization of it. But the ACGME requirements recommend 6 months of formal training prior to going in there, prior to beginning your fellowship training in interventional neuroradiology. And this includes formal training in the United Stroke Scale, obviously, if you're going to treat stroke. So kind of summing this up here. So if we added all of this up, you can see that this can become a pretty arduous pathway potentially. In the first column, we have the INR or ESN because the official name of the fellowship is Endovascular Surgical Neuroradiology. When it became an ACGME program, that name change came out, but most of us still call ourselves interventional neuroradiologists. But you can see the traditional pathway, you have the internship, you have your diagnostic radiology residency for 4 years, then you do your single year of neuroradiology, and then a year or two of interventional neuroradiology. And that's how a lot of programs are. It's really 2 years because there are an awful lot of cases, and we'll look at that a little bit. The neurosurgical pathway, if you went the traditional pathway that the ACGME specifies in the documents, there's the internship, and then there's the neurosurgical residency, because technically a fellowship is done after your residency. And so then the suggestion by the guidelines is that neurosurgeons would do a year of diagnostic neuroradiology before beginning their endovascular training. On the neurology side, in the last column, the internship, the neurology residency, then they recommend a cerebrovascular fellowship followed by a diagnostic neuroradiology fellowship, and then 2 years of training after that. So as you can see, it's a pretty long pathway. Having said that, these are the ACGME guidelines. Then if we look at the IR INR pathway, if you went the traditional pathway, you end up with your internship, your diagnostic radiology residency, your IR training, then your formal neuro training, if you follow the true, ACGME recommendations, and then you have your INR training afterwards. In any case, it's a long road. And being an IR, I was very happy to see the pathway, the IR residency, because I did a lot of things in radiology. I learned a lot, but I don't think I've done a single barium enema in the last 20 years. So moving along to the training program. So we talked about the ACGME requirements and the programs. And just yesterday, I went to the ACGME website and just double checked my numbers. So certified ACGME programs in interventional neuroradiology, those that are following all those rules to include that diagnostic neuroradiology year plus the training afterwards. There are only 3 radiology programs in the entire United States that are ACGME accredited. there are only 2 neurosurgery programs that are ACGME accredited and 1 neuroradiology program. So we all know there are tons of training programs out there, yet there are only 6 accredited pathways, 6 accredited ACGME programs. So what's going on? Well, what has happened, the first thing that happened is neurosurgery. So the neurosurgery programs, if you remember, have these very long pathways. And if you did your 7 years of neurosurgery residency and then you went off and back and did your quote unquote fellowship afterwards, that would extend it to 9 years at least. And what the neurosurgery programs have done is usually the 5th and 6th year, many of these programs are research years. And so what they've done is turned it into enfolded fellowships. So people are doing their fellowships during their residency before their chief year. And having done that, since there are only 6 ACGME programs, the neurosurgery side of the house, they came up with their own certification, a CAST certification to certify training programs. This will become important later when we start talking about the barriers to radiologists participating in stroke care. But on the ACGME side of things, with so few programs that are ACGME certified, that it's, the upshot of that is that you have 3 different specialties, radiology, neurosurgery, and neurology, that despite having an ACGME accredited pathway, there is no board examination at this point in time. And this pathway has been around for quite some time. So that's really what led AANS to create this CAST. They basically took things by the horns and created this. And it's their alternative. So the CAST guidelines are pretty stringent. I mean, they're not, they didn't shortcut things by any means. They are recommending 200 catheter-based diagnostic or interventional angiographic procedures before beginning training. So within the first 5 years of a neurosurgical residency, this is what they're recommending. And then you can see during those 2 years, they're recommending quite a few interventional cases. And this is a great caseload. I think it's absolutely appropriate caseload if you're going to be performing these procedures. 2 highlighted ones are the intracranial, extracranial stent procedures, and those become important from the fact of carotid stenting, and then 30 acute ischemic stroke interventions, which is kind of part of what this talk is about. But you can see it's a pretty good list and a pretty good mix of various kinds of procedures, and it's very appropriate. So moving from the various training guidelines, we move into the endovascular stroke therapy guidelines. This document is also from 2009, and this was put up by SIR, and the requirements are, if you start looking at them, the brain imaging, the interpretation of CT and head CTs and CT angiograms, MRIs, CT perfusion studies, and cerebral arteriograms. As radiologists, as radiology residents, you're going to get this background. The reading all, you're going to spend, I don't know how many months we spend nowadays. I spent 6 months total on neuroimaging. I certainly read that many MRIs and CTs. Perfusion didn't exist back then, but the number is relatively small. And then cerebral angiograms, there's definitely the opportunity to interpret and review that many. Then going on to performance procedures, again, that number of 100 comes up again. And so this document was actually put together looking at interventional radiologists performing endovascular stroke therapy before we had all the modern day equipment. So this is when we were really just putting microcatheters up into the middle cerebral artery and infusing thrombolytics, TPA specifically. And then when we finally got the Mercy device, which was at least the first dedicated device to endovascular treatment of stroke. That device is not used anymore because we have much better tools. But even with those early tools, these were the requirements, recommended requirements for training. And then also, if you look at the 30 selected microcatheter procedures, including 5 in the ICA/ECA, body IRs use microcatheters all the time. you're using microcatheters to do embolizations of the liver, for GI bleeders, for uterine fibroid embolization. So the catheter skills are clearly there. And then they were at that time recommending 5 proctored cases. So this was from the Society of Interventional Radiology. Carotid stenting, I'm going to touch on that because you have to stent the carotid, know how to stent a carotid if you're going to treat a stroke. Probably about 10% of cases, it's actually the carotid artery that needs treatment. And so the guidelines there, again, 6 months of formal cognitive neuroscience training. So you're kind of seeing a theme here, 100 diagnostic cerebral angiograms. You know, so this is in line with everything else that has already been published. The pathways, though, were a little different. You know, you can see here non-carotid stent procedures, hands-on training, and then supervised cases or consecutive cases of supervised stenting. So there's definitely a trend here, and that's really what my goal was to show you, is that this is something that SIR has been involved in for a very, very long period of time, discussing what the appropriate training guidelines are. And the previous two, the first document that I showed you from Dr. Connors, which showed training for all of cerebral vascular, that was actually a multi-society consensus document, which the neurosurgical societies and the neurology societies all agreed to. So across all specialties, there's a general agreement on what the minimum training is. So if we now kind of sum this up, we can see what's really happening in the middle column, when I talked about a little bit in neurosurgery with this enfolded fellowship, so 7 years. In neurology, it's kind of the same thing. And you notice between those two groups, what happened to that year of diagnostic neuroradiology? And that is, you know, I look at that and I know that as a radiologist, I had way more formal training in neuro, MR, and CT than either of these specialties. And so in my mind, if you were to get that similar training during your diagnostic radiology residency, I don't see any reason why you would need to have to do that formal year if you've interpreted enough studies during diagnostic radiology residency. And if you know you're interested in neurointerventional, you would probably gravitate toward those things anyway. Then you have your IR residency, and the reason I put a little asterisk there is I firmly believe that carotid stenting and stroke therapy are part of interventional radiology. When I was a interventional radiology resident, my first fellowship, I was performing carotid stents. That was part of my fellowship. We did at that time all the diagnostic cerebral angiography for vascular surgery before they did their endarterectomies. So we were doing 3 to 5 cerebral angiograms every week. And so we had a lot of experience in that, and I was fortunate enough to be involved in the first trials of carotid stenting before we had all this nice fancy equipment that we have now. We were crossing carotid stenoses with something called a TAD wire, which I'm not even sure exists anymore, and then we were putting a Rosen wire up into the ICA and using a biliary wall stent to stent the carotid artery without any distal protection devices. Obviously, things have come a long way since then. But the point of that is that I believe is well within the realm of interventional radiologists. One thing that is happening, there are discussions of the training pathways, and the requirement for 50 cerebral angiograms may be dropped from diagnostic neuroradiology. The neuro service line of SIR is working aggressively because we believe we don't want to lose that in the House of Radiology, and that really, I think, should be a requirement as part of interventional radiology, because it'll also, with that program requirement, now you'll get the experience because you have to. And then that would make that transition to the following year. If you decided you want to specialize in, to get further training in neurointerventional, then you go on to that 7th year, and now the training would be commensurate across all specialties. 7 years. It would be no different for a body IR wanting to do these other procedures. So I think from that standpoint, it's the big challenge is within the first portion of the training is to get the clinical training. So if during internship and residency you have time to do, it's essential if you're interested in neuro that you spend your time in the IC, in the neuro ICU, get those rotations on neurosurgery and neurology, and they will suit you very, very well. So we're going to switch gears. We've talked a lot about what the training guidelines are, what the various pathways are. So this is what stroke looks like in the United States right now. There are hospitals that are certified as acute study programs, and it's basically you need to have a CT scanner and somebody who's going to evaluate these patients. And these hospitals can administer IVTPA, and then they can transfer patients to a higher level of care afterwards. Primary stroke centers, that's a much more formalized training. Those hospitals have to have a very formal stroke program with a stroke coordinator, a stroke neurology service, and a place to keep patients in ICU if patients are getting IVTPA for monitoring afterwards. And then they have to have access to neurosurgical specialties. They don't have to be available 24/7, but access or the ability to transfer these patients to a higher level of care. Then the thrombectomy stroke center is a new designation that recently came out, and basically it has all the functions of a primary stroke center. However, there are dedicated neurointensive beds, and where those are, those can be in an ICU, those in a medical ICU, a surgical ICU, or even a dedicated neurointensive ICU. And they need to have on-site critical care in-house with angiography and stroke therapy available 24/7. And so that's a big jump there in that you have to have the critical care in-house 24/7, and that really relegates it in many cases to a vast majority of those hospitals will be teaching hospitals because of that. Finally, the upper level is the comprehensive stroke center. And what that provides is 24/7 care for all neurovascular disease. So not just stroke, but ruptured aneurysms, so subarachnoid hemorrhages, intracranial hemorrhage, intraparenchymal hemorrhage that can be from a ruptured arteriovenous malformation or just a bleed into the basal ganglia from hypertension. And then the ability to care for these patients and also having the in-house 24/7 neuro, not just critical care, they require neurocritical care. So somebody who is certified in neurocritical care be available 24/7. So that makes it, really it's going to be the teaching hospitals that are able to support that level of care. But this kind of gives you an idea of what the various levels are. So to be designated or noted for doing endovascular treatment, you can do this at a primary stroke center, but that's not, you don't have the designation. So in some states, what is happening is in hospitals that do not have the designation of a TSC or a CSC, the ambulance protocols are going in place to bypass these other hospitals if it doesn't delay care by more than 20 minutes. So if you're in a PSC and you're doing stroke care and suddenly this mandate comes out and there's a TSC or a CSC within 20 minutes, suddenly EMS is going to be bypassing you. So that's just from a hospital standpoint. We'll add to this a little bit. So this is from the most recent guidelines that came out. And what I want to bring to point is this. So we have the ACGME equivalent, which we know there are not many programs. We have the CAS certification, significantly more programs. So that already makes it challenging. Then there are these requirements for the number of cases actually done from JCO, which is actually interesting from the standpoint that actual numbers were specified to determine what is, what's the minimal number. And that's something that can be debated in many ways. But if you look at it and you imagine that there were 15 mechanical thrombectomies over 12 months, well, if you have 2 operators at this hospital, so from a call standpoint, you're now on every other night, you would need at least 30 cases or 30, over 2 years. So you need at least 60 cases, and that's doing Q2 call. I can tell you from having done Q2 call for the last 3 years, it's not a lot of fun. Kind of cramps your social life, as well as family time. So even if you went to 3 people on call, you now need to have 45 stroke cases, endovascular stroke cases a year at that hospital for everybody to maintain certification. If you double scrub, you could probably get, 2 people could count that, but over half of stroke cases happen after hours, after 5 and before 7 a.m. So it's a challenge cover. It's really from a call standpoint that it's the biggest challenge, is to cover this. And so this is why the bar is fairly high at the TSC and the CSC, is because you need to have the coverage from an endovascular standpoint, yet everybody needs to have enough experience. So it becomes an issue of having volumes. There is another organization, DNV, that is certifying hospitals for as thrombectomy stroke centers and comprehensive stroke centers, and they will certify centers. Even though JCO has certified the hospital, they will certify the stroke program in a JCO certified hospital. They have not, that organization did not decide to put the actual numerical requirements on the various operators there. They felt that was more should be left to the individual credentialing bodies at each institution. So that kind of, you get an idea of this. After the document, there was a multi-society document that SIR was not included in which they recommended formal neurointerventional training for all people involved in stroke therapy. And at SIR this past year, I had a meeting, I was able to attend the meeting with the Australian Society, the New Zealand Australian Interventional Radiology Society, and that paper that required the formal training, because the system there is centralized, the healthcare. The individuals there, it's mandated from the government, similar to the Canadian system. And so they were able to come down and say, if you have not done a formal neuroradiology fellowship, you can't practice stroke. And so what happened is, interventional radiologists who had been treating stroke for 8-10 years with good results, as good as any people who were formally trained in neuroendovascular training, and they are not legally allowed to continue treating stroke. And so this has caused a huge problem with resources, because there are not enough practitioners to begin with. And now when you take a fair number of people out of the pool, this has led in some cases to hospitals being held hostage by people saying, sure, I'll take neuroendovascular call because I'm endovascularly trained, but I'll do it for $5,000 a night. That's just not sustainable. And it's not good patient care either. So what has SIR been doing about all of this? So we are in the process right now of rewriting the stroke training guidelines. I am on the writing committee, and I can tell you that we're still working on it. Unfortunately, that will probably this calendar year before we finally have that done. The idea is that we will rewrite these training guidelines and get endorsement from CIRC as well as other international interventional radiology societies on these new guidelines. SIR has been offering the stroke course. This past year, we had our 3rd year. We expanded it from 1 to 1.5 days, which has allowed us to add half a day of perfusion imaging to it, hands-on training, which I think for those people who didn't have it during their residency, it's very helpful. Plus, it also achieves kind of an update. We have enough, because of the course, people get 8.5 hours of CME credit. For those of you who hope to be involved in stroke therapy at certified stroke centers, currently all the interventionalists are required to have 8 hours of CME dedicated purely to stroke. You can get it by going to meetings as well, but in this case, it's tagged on to the last part of SIR, and so it works out well for those interventional radiologists attending the meeting. We're also looking for a collaboration with the American College of Radiology to certify people for interpretation of cerebrovascular imaging studies. And this goes back to that whole issue of having read enough studies prior to your training, or at some point being certified, that you have, you'd like to think that having your board certification was enough, but alas, it's really, have you done your neuroradiology fellowship? And I really think that those people going through programs where they are doing stroke treatment at those academic centers, it is very plausible that during your residency you can get enough studies. The other point of this is for those who are out in practice right now, to kind of help break down barriers for them to get credentialed. If there's a question of, do they have the certification to do this? They can go, if this can be established, then they can go back and say, yep, here's my certification from the American College of Radiology that not only am I a board certified radiologist, but I do have the credentials to read these neurovascular studies. Finally, in the IR residency area, I was able to meet with the RRC chair, and we did talk about that alternate training pathway that I discussed earlier that would potentially allow those individuals who are interested in neurointervention, who are doing IR residencies, to be able to meet those prerequisite requirements and go directly into a neurointerventional fellowship after completing their IR residency. As part of that, things that we are working with the program directors, and I did meet with some of the people at SIR on that, is to reincorporate cerebral angiography back into the curriculum. That was left out for, I will tell you right now, political reasons, to be able to get things approved. But I think it's now, and I was very sad about that, because as I said, I did cerebral angiography. That was part of my interventional radiology fellowship, and we were doing a lot of it. Carotid stenting, same thing, should be part of the training. The stroke training as well. At UAMS, what I'm doing for that is I am actually having the interventional radiology fellows / residents rotating with me. They will spend 3 months on neurointerventional with me, getting formal training in cerebral angiography, carotid stenting, as well as stroke training. And then I already mentioned the INR path, the proposed INR pathway for IR residents. So I think that's about all I have right now. So I think we can open the floor to questions.
Excellent. Thank you so much, Dr. Radvany. That was an excellent presentation, very informative, and personally, I'm very excited to see and hear about all the work that's being done on this in terms of getting IR involved back again, making the INR fellowship perhaps a little bit more practical for some of the IR trainees who are interested in it. So for everyone who is attending, we will start taking questions now. I don't see any right now, and so the place you can do that is if you click on chat on your toolbar on the right side of your screen. You can type in your message and we will collect questions. And until then, I have a few to start things off. And my first question is something that you talked a little bit about. And in your opinion, how far away are we from having a INR fellowship available after IR residency?
I don't, well, it depends on if you want an ACGME accredited one or not. And that's really what it boils down to. There are fellowships out there all over the place. The question is, are they ACGME accredited? And I think that's the real challenge. I think ideally, all programs would be accredited, and there would potentially, just as with any other specialty where there is a formal training pathway, there would be a board examination so that then you have a certificate when you're done. So I think that's kind of the challenge right now. I don't know that right now with all the discussion and things changing as quickly as they are, I don't think that board certification is going to be a reality for any specialty. Neuroradiology, for radiology, neurosurgery, or neurology. I think what's at this point in time, it's really a plan to, you just need to get the training. Now, having said that, there are discussions going on in the background between the Society of Interventional Radiology and the Society of Neurointerventional Surgery, of which I'm a part as well, as to how interventional radiologists, there can become a pathway to get into the INR fellowship, and this alternate pathway we're discussing, and for that matter, to be certified if you don't want to go that full route, but to be able to treat stroke and do carotid stenting and cerebral angiography. Because I think, as I said, I think it's really part of the training of an IR. It was when I went through, and I don't see any reason why that should change. And so I think that's one of the, that's the long answer. I don't think there's anything formal coming right now, but hopefully there will be a pathway for IRs who want to at least do stroke and carotid stenting and be able to participate in stroke care at certified centers.
In regards to that, do you think, so it sounds like this is kind of in its infancy. As you said, there's no specific sort of plans for accreditation, at least at this time, for that pathway for IR. For a trainee who's going into IR, perhaps matched into an IR residency or a diagnostic radiology residency, and they think this is something that they want to do, in other words, to do IR and INR, what are some things that they can do in terms of speaking with their program directors, or things that they might need to be cognizant of?
Yeah, well, I think what would be, in the big barriers, if you look at them, are really probably the biggest one. It's getting the angiographic experience and also the clinical experience. And I think that's probably the more difficult of the two. I would say that if during the internship year and the residency year, if there is flexible time there, get that 6 months of training, a couple months in neurosurgery, a couple months in stroke neurology, neurology, as well as in the critical care time. Now, obviously, that doesn't necessarily have to be all during the internship year, but if you can get 3 months during your internship year and then 3 more months scattered, during those first couple years of radiology residency, then you've really laid the clinical groundwork, and you have now the clinical background to take care of these patients. The rest of it, the imaging portion of it, that's going to come during the residency, and then you have to just make an effort to get involved in the neurovascular procedures. So your case log can reflect the fact that, yes, you have actually been involved in these kinds of cases.
Excellent, thank you. Another question I have before I start reading some of the questions we've received is, do you have any recommendations for residents or students who are currently at smaller programs with minimal INR exposure on how to gain experience?
Well, if you can do rotations away, I know it's very variable from institution to institution. I know that I actually, I was in the military, and we did not have, in Hawaii, our IR program at the time, we did not have a lot of cases. And so there was an agreement for the surgical residents to rotate over at Kaiser. And under that same umbrella, I was actually able to go rotate with the private practice physicians over at Kaiser who were doing body IR, and I got a lot of great experience. So that's, one of the ways if your institution has an agreement with for away rotations, I think that would be a great way to try and gain some extra experience.
Great. And my last question before I'll start reading from some of the asked questions, and it looks like we've got a couple, is, and this is particularly addressed to you, and I know there's a few others who are active in the society as well, who have a somewhat similar background to you in terms of being kind of dual trained in IR and INR. My question is, what do you think is the value of a physician who is dual trained in IR and INR, as opposed to a physician who goes through the more traditional pathway through neuroradiology and INR without the body IR expertise?
I think it depends on what you want to do for a living. So I've worked in the military, I've worked in private practice, and I've worked at big academic institutions. And I think it really boils down to what are you going to do with your time and what are your interests. In private practice, you need to be doing something. And depending on the size of the group, you maybe have a challenging time finding a pure IR job, much less a pure INR job. And so if you are able to do INR and body IR, that makes you very, very marketable. At the same time, advantages of doing IR and INR and diagnostic neuroradiology is you never know what's going to happen long term. You know, your back can give out. And intervention in general may not be in your line, body or neuro, but you can always, go back and read film and still make a living. I know it's kind of a morbid way of looking at things, or less than optimistic, but it does happen. If you're, unless you're at a very busy place, like a major academic institution, or you happen to find a private practice that's super busy, you're going to end up doing INR and something else to stay busy. The private practice group is going to want you doing that. That's when I was up in Pennsylvania, because there's just not enough to work to keep you busy. Yep, you're taking a lot of call, but call doesn't equal RVUs. And in private practice, that's something that's going to be looked at very closely. It's looked at in academics as well, but there's a certain amount of leeway if you're productive in other areas like research. Private practice, they don't give a darn about research. They could care less if you write a paper or if you're involved in any committee outside the hospital. Doesn't matter. Are you on the treadmill generating RVUs? So I think the other training, it gives you the opportunity by having that other piece, especially if you're in a, out in the community. And let's face it, the vast majority of practice in the United States is in the private practice area. Coming through, as a medical student and then going off to residency, few people, I think, realize what a large proportion of the practice going on is really private practice and otherwise, because we spend so much of our times in our early training in academic institutions, and this is the life we know and this is what we understand. And then when we leave that and we go out into the big wide world, we see that things are very different potentially.
Well, thank you for that very informative response. I think obviously there's a lot to consider in all this, and we're very appreciative of your perspective. And looks like we have a few questions here from the audience, which I'll now read from. First question is from Kevin Carr, and Kevin asks, does the proposed pathway for stroke care through IR include other procedures such as AVM, intracranial aneurysm treatment, or tumor embolization?
I'm sorry, the proposed pathway for IR?
For stroke care through IR. So one of the things you talked about, kind of helping IR trainees get that experience.
There's a definite line in the sand. If you want to embolize aneurysms and AVMs, you need a formal fellowship. You're going to need another year after the formal IR year, because that training, it really, if you want to start doing that high level of work, that really does require a full fellowship after you finish your IR. To do stroke and carotid stenting and cerebral angiography, that is really within the realm of IR.
Okay, pretty definitive, I think. And next question from Ghassan Ahmad, and Ghassan asks about the programs that are not ACGME or CAST accredited as of yet. Do they have problems becoming credentialed at hospitals? And I think he's referring to graduates of those fellowships. Do they have problems becoming credentialed?
It really depends on the individual institution. If you have a case log showing you've done a appropriate number of cases and you have done, completed them successfully with all your follow-up, it's really up to the local hospital to decide whether or not they want to give you credentials to do these procedures. We all know that there are other specialties that do what we consider traditionally IR procedures, and we see them done at varying levels of skill. Yet all those practitioners are credentialed to do those procedures at the individual hospital. So I think it's really becomes really more of a hospital-based thing. Obviously, if you have more certificates and piles of paper saying that you've done all these things, it's a little bit easier, but it really comes down to the individual hospital level of what they want to credential you for.
Let's see. So essentially, a case-by-case basis is sort of the answer there.
Yeah, it is case by case. Obviously, it's easier the more supporting paperwork you have.
Right. And another question, also from Ghassan, is are there any IR programs that have an integrated INR curriculum for candidates? Are you aware of anything like that?
Well, I mentioned that what we're doing here at UIMS is similar to what Brown has. Brown, their IR residents spend 3 months on neurointerventional at that institution, and I think there may be a couple others that do that, but I don't know off the top of my head any others. So I wish I could tell you more. Michigan may do that. University of Michigan, Joe Gametti's program. But it's really, this is something that's moving very quickly with all the changes that are going on. As I said, they're considering dropping the requirement of 50 cerebral angiograms from diagnostic neuroradiology fellowships. So again, if that really happens, how is each institution going to, address that? It's not required anymore, but if the neuroradiologists there want to keep doing these, they'll keep doing them and it'll be part of the training. So this is something that's in process of evolution right now.
Great. So I think that's something we can all take away from this is an area where there's a lot of change going on right now. I know that many of the people who are attending this webinar are obviously interested in this area. And so I urge you all just to stay in the loop and stay involved with things coming outside of the neurointerventional service line from the RFS. And I would also, on that note, like to plug again our next webinar, which will be this Sunday at, again, 8 p.m. Eastern Time. And we'll be hearing from Dr. Dons about an IR perspective in stroke care and talking about some of the jobs where actually IRs are still handling some of the stroke interventions in predominantly community practice. So I think that will be kind of a nice perspective to augment what we've talked about tonight. And I want to see, I think those are all the questions that we have. So with that, we'll conclude this. And I want to thank you, Dr. Radvany. This is an excellent talk. I can personally say I learned a lot from this and find a lot to be excited about. And thank you for all your work in this area and especially preparing this presentation for us.
You're welcome, and good luck to everybody. Good luck to you and good luck to everybody in the audience.
Okay, thank you very much. All right, everybody, thank you again for joining us. Oh, sorry, it looks like one more question snuck in.
Okay.
A buzzer beater. Oh, this is a very interesting question, actually. When discussing training requirements at these national meetings, does it feel like a turf war between neurology, neurosurgery, and radiology?
I would, I think it depends on who you're talking to. If you talk to those individuals who are involved in some of these, these higher level committees with the certification of centers, most of them are from academic centers. And in many cases, it's about patient care. It's really what is the best for patients. And that's why there's this whole struggle with the primary and thrombectomy ready centers and comprehensive stroke centers, because what is enough care? What is enough backup care and coverage? Out at the community, and that's the big challenge with stroke. Stroke is so time sensitive that getting patients from one institution to another where you can provide this certified higher level of service Is that, it's probably in the patient's best interest. The challenge is providing care to patients throughout the United States, because if you live in a big city like LA, Chicago, New York, or any other big DC, we're tripping over each other. There are so many people, engaged there, and it becomes in some ways, it may be a little bit of a turf thing. When you get out into the more rural communities, it's more about how do we get this patient taken care of? We need to get these patients taken care of. So I think part of it has, in general, if there's more work than can be done, everybody's happy to have a little help. It's when you're, fighting for cases, that's when it becomes a turf war. So I think it really depends on where the author of the comments is coming from, what the intent and potential interpretation would be.
Absolutely. Thank you for that answer. And thank you for that question. Very, I think, important one to talk about. So everybody, thank you very much for attending. And again, Dr. Radvany, thank you so much for your time this evening. And we truly appreciate it.
All right. Thank you for having me.
Okay. All right. Good night, everybody.
Good night.